Hello, my name is Eric Strong, and I'm a professor at Stanford School of Medicine. This is an introduction to a brief series on oral presentations and medical documentation intended primarily for medical PA and NP students. In this series, I'll be discussing the medical history and physical exam, commonly known as the H&P, so-called SOAP presentations and notes, an alternative to SOAP, which I think is actually better, and discharge summaries. I'll also be incorporating some examples of presentations. In this introduction, I'll be discussing a few things that apply to all forms of presentations and medical documentation in general. To start, what is the purpose of presentations and documentation? Whether you're considering an H&P, SOAP note, or discharge summary, or are considering oral versus written forms, the primary purpose of all of them is communication. The information that's communicated includes, most obviously, data about a patient's medical history, their current condition, test results, and treatments provided. But it's more than that. It also includes information about your own thought process, what it is that you think is going on with the patient. What diagnoses do you think are most likely to explain their condition, and why do you think that? How does the data support your conclusions? And last, how did you decide on the plan of care? Originally, presentations and notes were composed by physicians with a primary intended audience of only other physicians. However, over time, their purpose has grown in scope, and with the increasingly complex delivery of care, the audience has become much more diverse. So today, it's not just about communication between physicians, it's also about communication between physicians and advanced practice providers, such as physician assistants and nurse practitioners. Communication also extends to the patient's entire healthcare team, including, but not limited to, nurses, respiratory therapists, physical and occupational therapists, case managers, dietitians, and pharmacists. For better or worse, in some countries, including here in the US, written notes are also a way to communicate to insurance companies in order to justify medical billing and to compare patient outcomes between institutions. Notes in the medical chart are legal documents that can be examined and used as evidence in court in the event of an adverse patient outcome. And more recently, with the ability of many patients to access their medical chart electronically in real time, a model known as open notes, the notes can communicate information directly to patients themselves. Specifically regarding the written notes of today, with such a diversity of purposes and audiences, they often fall short of perfectly addressing any one specific purpose. Each individual reader might find only a small portion of the content to be relevant to their needs. The notes can be bloated with unhelpful, auto-populated, and cut-and-pasted nonsense that is not even accurate. They can lack a coherent description of the clinician's thought process. They can be full of jargon and acronyms that are not only incomprehensible to patients, but also to any healthcare professional from a different specialty than the writer. My intention with this series is to teach you and to show you how medical notes and oral presentations can still be valuable tools in the delivery of modern healthcare if we adhere to some fundamental principles and a consistent format and organization. There are some specific tips related to the electronic medical record, or EMR. In most places in the world, including every hospital in the United States, notes such as H&Ps and SOAP notes are composed directly in the EMR using templates which auto-populate a large variety of data. This can include past medical history, medication lists, smoking and alcohol history, vital signs, and lab results. It's very common for busy, multitasking clinicians to just run with this auto-populated information without even checking it, let alone editing it for clarity. But particularly for students, I strongly encourage you to do so. As just implied, the auto-populated information is wrong with surprising frequency. At the absolute minimum, you should ensure that the past medical history is updated and completely resolved issues have been removed, and that the outpatient medication lists have been confirmed with the patient. In many cases, the process of auto-populating templates can place equal emphasis on data of vastly different importance, So a patient's auto-populated problem list might have 30 items in which their heart transplant is sandwiched between halitosis and heartburn. There are also tips for documenting in the era of open notes, which, as I mentioned, is when patients can access their own medical records in real time. In short, keep in mind that anything you write in the chart could potentially be read by the patient the same day. Not that it was ever okay to be judgmental or rude in the chart beforehand, but this is even more motivation to keep everything you document as justifiable, supported, objective, and professional as possible. I personally don't think that open notes means that we should discard virtually all medical terminology to make the notes maximally readable by patients. Now, a vocal minority of clinicians do advocate for that, but I think doing so leads to ambiguity and less precision in communication, and in my experience, most patients don't want that. They want access to the information, but they don't want the information watered down. However, I do think you should err on the side of avoiding unnecessary obscure acronyms. You should be extra cautious with documentation around mental health, substance use, and sexual history. And you should abolish the use of stigmatizing and more subtly coded language in charts, which you might think is providing helpful information to other clinicians, but which often perpetuates bias and is infuriating to patients when they pick up on it. Let's see some examples of language that's problematic. There is language which questions the patient's credibility. The patient claims that ibuprofen is ineffective, or the patient denies recent alcohol use. Instead of claiming or denying, the patient reports something did or did not help, or did or did not happen. Language which is judgmental. The patient refuses vaccination due to conspiracy theories her cousin shared on social media. Instead, the patient is declining vaccination due to concerns regarding toxicity and side effects. Language which suggests the patient is difficult. The patient is well known to me from countless visits to our ER related to his ongoing drug abuse. We can change that to, I am familiar with this patient from a prior ER visit. Language which is inherently paternalistic. The patient refused her morning labs. Although there are extreme circumstances in which the word refused is appropriate, for example, the patient refused emergent surgery for their type A aortic dissection, but in most cases the word declined is preferable. Language easily misinterpreted by someone unfamiliar with medical terminology. The patient's SOB returned yesterday. SOB is an outdated acronym for shortness of breath, but in American English, it is also a semi-profane slang term. Language which is inherently offensive. The child is an FLK, which FLK is an acronym for funny-looking kid, meaning someone appearing syndromic. And as awful as that sounds, it was a very common term thrown around when I was in medical school. And last, the use of quotes to highlight poor medical literacy. The patient reported she ran out of her, quote, sugar pill weeks ago. I want to be transparent with medical notes and artificial intelligence. We aren't there yet in 2024, but for any first-year student, by the time you are finished training and are practicing independently, so by the early 2030s, I expect that AI will be playing a significant role in medical documentation. Precisely what that role will look like is not yet clear, and will certainly evolve over time. It may start with AI suggesting a problem list from the preceding note and diagnostic data. Chatbots based on large language models, including ChatGPT, can already do this as well, if not better, than first and second year medical students. How soon will it be until a computer listens in on our patient interview and, combined with mining the medical chart for additional data, auto-composes the history of present illness in an H&P? And how long will it be after that until we provide the computer just our physical exam, and the AI composes the entire note, including the assessment and plan, needing us to just edit a few things here and there? No one can offer specific timeframes for when these changes will happen. But it's not just a matter of the technology, because the technology is more or less already there. These AI tools also must be demonstrated to be safe, and there will be non-trivial legal and regulatory hurdles to overcome. For example, who would be responsible for harm caused by an error in an AI-composed medical note? However, these changes, they are coming at some point within our lifetimes. With that in mind, I appreciate that it might seem unnecessary to master a task that eventually will be predominantly outsourced to technology. Yet these are still important skills for clinicians in training to learn today because the technology hasn't been implemented yet, and we can't predict when that will happen. We will need clinicians familiar with how to optimally communicate information in order to implement these changes in a way that is safe and improves patient care, and it's never going to be perfect. As an analogy, think of ECG machines and their ability to diagnose arrhythmias on their own. Are ECGs frequently correct? Yes. A time saver for overworked ER docs? Yes. A useful support tool for staff not well trained in ECG interpretation? Also yes. Always correct? Definitely no. An experienced clinician comfortable with ECGs can still outperform the machine algorithms on complex arrhythmias. It will be a long time before there is no role at all for human intervention in medical documentation. Now, perhaps in 25 years, this video series and this entire skill set will be obsolete, but for now, writing medical notes remains a core skill in medical practice, and delivering oral presentations remains a core part of student education. I'll end this introduction with a final word of advice for students who are learning these skills for the first time. Practice. Practice oral presentations, and to a lesser extent, practice writing notes. The ability to give a clear and organized oral presentation, which includes a level of detail appropriate to the patient and situation, will play a disproportionately large role in your evaluation by faculty. This is a little ironic since fully licensed and independent clinicians rarely, if ever, need to give an oral presentation. But remember that oral presentations and written notes are not just a way of you reporting and documenting objective information. They are also your opportunity to explain your clinical reasoning. That is, why you think one diagnosis is more likely than another, and why you think certain treatments are more appropriate than others in a particular patient. Presentations and notes are an excellent way for faculty to assess whether a student or intern is able to understand and apply very practical medical knowledge in real-life situations. Personally, I learned more about a student's knowledge and reasoning skills from a single oral presentation on a new complex patient than I ever could from a traditional written exam. So practice. Proactively request feedback, reflect on it, and incorporate it for next time.